Again, my name is Dr. Gil Salazar. I'm the medical director for the UT Southwestern EMS education program. You might remember Paul Rosenberger. He's my right-hand person, and he drove a long way to come here from the great town of Flower Mound. I drove a whopping 5 minutes from Lucas, so it's great. It's fantastic. A big thank you once again to your leadership, Chief Boyd, Chief Williams. Tony, you were very, very kind in inviting us back. We had a great time with you last time, and we think that what we have to offer is a good product. So our mission today, ladies and gents, is to offer you a little bit of extra education today. We're going to be discussing thoracic, abdominal, and pelvic trauma today. My main goal is to emphasize some things that you should already know, but also more importantly to bring some concepts to the table that may be kind of coming up that you may not be aware of and that are going to drive the future of EMS when it comes to this type of trauma. Just to kind of get things started, I'm hoping to get you out of here way before our scheduled 4 o'clock. I don't want to be a talking head for however many hours. That's not the way I roll. I know that you don't want that, so we'll do our best to get you out of here way before. In order to do that, remember our sections are going to be pretty interactive. I want your feedback. I want to see kind of what you guys do, what you're used to, kind of drive the conversation a little bit. So please feel free to jump in. That's what we're here for. Answer any questions that you have. Okay. To start off, we know for sure that thoracic, abdominal, and pelvic trauma kill. To give you an example, when this was driven into my head, we are so used to taking care of people that we're almost robotic at what we do, okay? But on July 7th, 2016, my robotic mindset went to the toilet, okay? When 5 Dallas officers came to Parkland Hospital, where I practice, all with large caliber gunshot wounds, mostly to the thorax. None of those officers made it, okay? There were other officers that sustained other injuries and they survived, but you know, the injuries those 5 officers suffered on that day kind of made me reconsider the way I was thinking about my robotic way of doing things, putting a little bit of a face with trauma, and so I'm going to dedicate this lecture to those officers, okay? We're also going to be discussing some of their injuries, which are very pertinent to this, and I do it not to bring back bad memories, but as a way of honoring their memory, is using their experience and their ultimate death in helping save others' lives. Okay? All right. Now, there is an ugly guy here. You might recognize him. Any idea who that may be?
Just ain't here, dude.
That's before a 20-year-old daughter.
That's Paul Rosenberger back in 1990, okay? In kind of Tarrant County on those days. Yeah.
That sign on the right side.
This gentleman went into wasn't an argument, right, Paul? It was one of those deals where you kind of get called outside to discuss some things, and things are not resolved with fists. And what did the other guy do to him? He shot him. Okay, a couple of injuries. Now, let me kind of go through this picture, which I really think it's a very cool historic picture in many, many ways, because Paul's such a good friend. I love to make fun of him. He's very old, but it really brings up a lot of cool points in here. So, just anybody, tell me what kinds of things strike at you, particularly things that we probably don't do anymore. Yeah, mask trousers. Yep, that's a big one. You see, yeah, absolutely. Little Dr. Rosenberger didn't read his modules on infection control.
We weren't used to gloves back then.
That's right. Yeah, just a couple of them. Yeah. Yeah. What's that? Anything else strike you? All right, I'm going to point some things out. Notice what the medic is doing here, establishing an airway and penetrating trauma right here, okay? We're going to discuss some items regarding this picture and why what we were doing back then is not the correct thing to do. So somebody mentioned mask trousers. Good Lord, it's a long time ago, okay? Infection control, etc. But just to kind of reemphasize the point, we've changed our mindset on a lot of things, and we learned a lot of good lessons from what we used to do, and our survival rate was crap.
This guy did not survive.
He did not survive, not at all. Okay, so we'll think about this type of level of injury and discuss some aspects of his care. Mr. Sullivan, would you be so kind as to help us with case number 1? Whereas we get dispatched, this was the, where's the, oh yeah, here we go. We get to an exit ramp right off of 75. A driver hits a stalled vehicle. They call you out. Tell me a little bit about the response that you guys do here in town for something like this, freeway, accident, off a ramp.
If it's on the highway, we get two, either a truck or engine or two engines, whichever one, a battalion.
Awesome. All right. We know that the driver was distracted on his phone and struck a stopped vehicle. Hey guys, how are you? And we know that what kind of resources you already have. I like the resources that you dedicate to it. Let me give you a little more information to it. What kinds of things do you want to know about as you get there?
He responses, is the vehicle on fire? Was he restrained? Do you have easy access to it? Or do we need to pop the door or use it, extricate him out? Is he breathing?
Good.
Was there any other people involved in the wreck? Either in the stalled car or in that nature? How many people were in the vehicle?
Excellent. All right. So let me give you a little more information. We know that the driver was going pretty fast, 80 miles per hour. We mentioned he struck a vehicle. We know that he was restrained. The airbags got deployed. So you know you have really one victim at this point. The rest are fine. No big deal. I'm going to give you some assessment findings. You know there's really nothing in the mouth. Right there, you notice that the patient's respiratory rate is a little elevated. He's got good radial pulses. He's alert, awake, and talking to you. He's got a couple of cuts on his face. Nothing really bleeding at that point. All right. What do you guys think of a capillary refill as an exam finding? Is that something that we do on a regular basis now? When's the last time y'all checked the cap refill? Yeah. Here to tell you kind of as the first teaching point, your radial pulses in and of itself along with mental status are going to give you all the information that you want about the patient's perfusion. And so these days we spend a lot of time on capillary refill. It's like, is that 3? Is that 2? Is that 1? It really doesn't matter. Let's focus on mental status and a radial pulse, okay? With a radial pulse and the patient maintaining fine, you know that no matter what is happening, you still have enough perfusion to get you through the day. Anybody want some vital signs at this point? Yeah? Okay. Here we go. Heart rate, a little elevated. Blood pressure, 103/71. A little tachypneic. End-tidal CO2. Kind of where it needs to be. O2 sat a little bit low. We check a glucose. That's pretty normal as well. GCS is 15. Mr. Sullivan, what do you want to do with this patient?
As far as we need to get him out.
Okay.
He's not, obviously, his heart rate's a little elevated, which is predicted with the event. Probably need to take, if he's complaining neck or back pain, take some cease-time precautions.
Okay.
Assess on if he's with a dash is rolled down on him, or if he's pinned in on the door. See if he can move, if he has feelings in his legs, and he has any pain down there associated with it, any abdominal pain, and then work on getting him out.
I like it. That's a good way to start. Absolutely. What do you guys think about this set of vital signs? What strikes you? What strikes you from it? Temperature. What worries you about the temperature? Doesn't fit. Okay, I like that. Anybody else? Any other concerns?
I mean, I'd like to know if he knows what his normal pressure is, because with being tachycardic, that's borderline hypotensive there.
Okay, very good, very good. Anybody worried about the heart rate? A little low, a little bit high. Okay, all right. Here's lesson number 2 for the day. While we are discussing things, and for all our friends through here, I'm just gonna say it. I want you to remember this formula. We taught you this in medic school. I'm going to just reteach it to you, and I'll tell you why in a second. Your cardiac output is really what drives our perfusion going forward from the heart to brain, lungs, kidneys, everything, all right? That is determined by the heart rate times the stroke volume, all right? Stroke volume is our volume, our internal blood. We have about 5 liters of blood at any one point. That's our stroke volume. So something I want you to remember going forward is anytime you see heart rate like that, you got to be wondering why it's elevated. Okay? Is he in pain? Is he anxious? Or are we trying to compensate for a decrease in stroke volume to maintain our cardiac output? Remember, he's maintaining well with a good radial pulse, so he's maintaining his cardiac output. I want to be very cautious in saying, he's in pain, he's a little nervous, a little anxious. Always think to yourselves, is he compensating for a decrease in stroke volume at that point? Okay? Now, the gentleman in the back, what was your last name, sir? Mr. Harrison? I think it's Mr. Harrison back there. Brought up a very good point. What do you guys think about the blood pressure in this patient? It's a little bit low. If he was, we always worry about 90s, right? 80s or 90s systolic. Does this worry anybody at that point?
My resting blood pressure is higher than that.
Okay, all right.
For being trauma related, it's not like a big eye catcher of, oh my gosh, I got to do something now about it. But yes,
Okay.
It is something that you need to assess once you get him out.
Okay. Do you think this should be a little bit higher if he's really doing as well as we think he is? Do we think it should be higher?
Yeah.
I really think so too. So then Mr. Harrison brought up a good point. It's like, why is this so? Why is this the way it is? It should be a little bit higher. If he's mounting a tachycardia to compensate for something, that cardiac output should be a little bit bigger. So there's something off about that. All right. Now, let me go back to our ample history to make that point across. Okay. What kinds of medications that would you want to know about that could be very important in the management of this patient and vital signs? What kinds of things would you want to know about? Blood thinners. Okay. Any other ones?
Beta blockers.
Beta blockers, calcium channel blockers. So now let me put a scenario for you. We have a 47-year-old. The vast majority of 47-year-olds, unfortunately, in our society are not healthy. They're not 120 over 80, okay? If they were 120 over 80, then that would be fantastic, but that's not the reality. The reality is this patient more than likely generally lives in the 150s, 160s, 170s systolic. So that when we look at a blood pressure of 103 over 71, that is hypotensive for that patient, okay? They've been used to a certain MAP, a certain map for a long time. This is actually hypotensive. So always take vital signs with a grain of salt and think to yourselves, you know what? That's great. It's kind of normal-ish, but for a patient who is 47 and normally lives in the 150s, 160s, 170s, that's actually pretty low. Now, on top of that, we have a heart rate of 113. He's probably losing volume somewhere, all right? Now, where could he be losing volume from, you think?
Spleen.
The spleen? Cool. Anywhere else? Abdomen, yeah. Any other structures in the abdomen that bleed a lot? Spleen is one.
Spleen, liver.
Liver's a big one. Okay, yeah. Yeah, absolutely. Aortic tears, bowel tears, all of these things can bleed. And let's not forget our thorax, all right? Now, somebody mentioned blood thinners. What kinds of blood thinners do we know or worry about? What's that? Warfarin, Eliquis, Plavix. Okay, cool. Now, I'm going to ask you guys a question. How do you think companies come up with awesome names like Xarelto, Eliquis, etc.? Anybody know?
Drunk at a party.
Drunk at a party. Close. You know what they do? These companies hire people like you and me. They go to focus groups and they ask us like, tell me what you think about this name. Is it sexy enough for you? How does it make you feel? And they drive these names so that we remember them. And that's why we're more likely to remember them. We don't ever remember the generics. Now, if you look at a patient's medications now, and they hand you a bottle, do you think they say Xarelto, Eliquis? No, they really don't. They have the generics, okay? So lesson number 3 for the day, I'm going to teach you a very basic skill in recognizing, because the patient may not be awake and alert talking to you. All you may have is a pill bottle, and that's about it, all right? So these are the 3 I want you to remember. Anything that ends in tran or ban, these are the direct oral anticoagulants, the modern ones, all right? Some of our patients who are uninsured, they don't have a lot of money, maybe on some of the older ones like Coumadin, warfarin, but you're gonna start seeing more and more patients walking around taking these DOACs, direct oral anticoagulants, all right? So I want you to I don't want you to remember the names, but I do want you to remember tran, ban, and ban, because if you see that, that's an anticoagulant. It may not say Eliquis, by the way. This is Pradaxa, this is Eliquis, and this is Xarelto, okay? But if you see those, think to yourself, that's an anticoagulant. I need to worry about that patient, all right? Okay, awesome. Speaking of else, we got a little bit of a sample history. What else? What would we want to know about the patient's last oral intake? What difference does that make for you? Does it make a difference at all?
For us?
Yeah, not that much. Does it make a difference for anybody else? Surgery. Okay, cool. In my humble opinion, in the setting of thoracic, abdominal, and pelvic trauma, the only L we really got to worry about is last meal. Why? Because if we need to do any really a truly emergent airway procedure, well, we know they're going to have a full stomach. And 2, it really helps us in the hospital to kind of tease out when's the best time to take that patient to the operating room. All right. The second L to worry about is in women is the last menstrual period. That changes your management completely. Thoracic, abdominal, and pelvic trauma in a pregnant patient, that's a completely different animal. Okay, so a last menstrual period and a last oral intake are the only L's you should worry about. Last bowel movement, all that crap that they teach us in medic school, that doesn't change your management in the least. All right, cool. So now we have a cervical collar. We have a basic assessment of the patient. We've done some basic interventions. I'm going to give you the rest of the physical exam here. We mentioned the abrasions to the face. We know that we are going to listen to breath sounds that are equal bilaterally. We don't have any decreased breath sounds anywhere. But when we come to the abdomen, we have diffuse tenderness. There's no seatbelt sign on there, no other markings. So now what, ladies and gents? Does anything come up higher in our list of priorities or concerns for this patient? Bleeding? Okay, very cool. Bleeding where? In the abdomen? All right, awesome. We mentioned spleen, we mentioned liver, we mentioned aorta, bowel, places that can bleed. In this patient with blunt trauma, which organ is most likely to be damaged if we're hemorrhaging?
Spleen and liver.
Spleen, big one. That's going to be the most likely. What about in penetrating trauma? Liver. Yeah, the liver is far bigger. Takes up all of our hemiquadrant here. The spleen is only the size of our fist, well hidden under there. So blunt trauma is more likely to cause splenic injury. All right. What do we want to do with this patient? Where do they go under your protocol? Okay, cool. Let's discuss some specific points about this gentleman. All right. I want you to remember the following. Abdominal pain and or abdominal tenderness in the setting of blunt trauma equals intraperitoneal hemorrhage until proven otherwise. All right? You may have no markings whatsoever. You may not even have any vital sign abnormalities. We're very lucky this patient does have some vital sign abnormalities to make you suspicious of it, but always think to yourself, does my patient have an intra-abdominal hemorrhage that is causing what I'm seeing? Therefore, a high level of suspicion is absolutely necessary in these patients. These are the main points I want you to get out of that case. Talk to me a little bit about your interventions right here. I want to focus on your spinal motion restriction just for curiosity's sake. Do we wanted to immobilize that patient? What kinds of patients do not get immobilized? Or what criteria do you guys use? I already know them, so. Good. Cool. Any other ones? So if a patient says, my neck hurts, can we clear them clinically in the field? Nah, they get immobilized. And then you said, what was the second one you said? Okay, so a neurological deficit, having back pain or loss of consciousness, or they say, my hands feel numb, that's a no-go. What other ones get immobilized no matter what? What about age? Is there an age cutoff? Patients over the age of 65 with any concerning mechanisms are not good candidates for clearing C-spines in the field. They're an automatic one. Now, we talk about distracting injuries all the time. That's another one. If a patient has a distracting injury, then they're not candidates for that. Do we have a distracting injury on this? Yeah? Okay. Yeah, my opinion is yes. The patient is tender. They're complaining of abdominal pain. And even if the patient wasn't, your suspicion for intra-abdominal injury is high enough that I would immobilize that patient. Plus, you have a high-level mechanism. They're going to go to a trauma center. Well worth your while considering your SMR. All right? What do we want to do about that SpO2? It was 95%. Do we leave it alone? Anybody want to do a nasal cannula or non-rebreather? Leave it where it be?
Leave it for now and assess later.
Cool. Is there an optimal way of assessing ventilation that we have readily available to us? We have an SpO2. Is there a better way? End-tidal 100%, gents and lady. We have a 38 in our millimeters of mercury for end-tidal CO2. I am happy where we are. No need to start him on a non-rebreather, not even a nasal cannula. The patient will do just fine without oxygen. Okay? Let's focus now on ALS interventions. Let's talk about fluids. That patient had a blood pressure of 103 over 62, if I remember correctly. When do we want to start fluids on people?
Like during their
Yeah, it's
call
also
or-
65.
Like this one. Just do a map of 65. Is there a more practical way? Yeah, our monitors are good. Is there a more practical way of deciding when we need IV fluids on people?
I mean, look at your patient. If they look like crap, then you're probably going to start some.
Okay. We're going to run into some cases in which the patients are more hypotensive. One of the more practical ways of doing it, especially in a really bad call, stressful, or dangerous situation, if we don't have a radial pulse on the patient, they're a good candidate for IV fluids. Your protocol calls for 10 mLs per kg initial bolus. You can repeat that up to two more times, okay? Only if needed. In a little while, we're going to discuss some new novel ways of taking care of volume in the field, okay? Would you give this patient something for pain or no? How much?
If he's in a lot of pain, probably some chemicals,
I like that. I like that. That's a good option. Last class wanted some fentanyl. That's not a bad choice. I like that. Yeah, they could use something for pain.
if you're kind of worried about his shock state, then will kind of be more Labrador as an add-on and give 100% ketamine on.
I like that. I like that. Absolutely. That's a great choice. All right. So summary key points for this one. Abdominal pain after trauma. That's hemorrhage to me until proven otherwise. And therefore things may look okay for a while, but you got to remember, especially if your patient is tachycardic, because they're losing volume sooner or later, this is going to tank, this is going to keep going up, and your cardiac output is going to go to crap. And so we got to keep a close eye on the patient. All right? In your SMR, remember actual findings such as tenderness, markings, wounds, etc. on the cervical spine, distracting injuries. The patient is intoxicated, on drugs. They may be elderly, for example. Not a good story. And also, remember, the patient complains of back, neck pain, or have a neurological deficit or symptom. They're not good candidates for that. All right? Okay, very good. Any questions about case number 1? No? Everybody got to remember Tran, Ban, and Ban? That's an easy way to remember them. All right, Mr. Gibson, can you do case number 2 for us? You have grandma. She was trying to reach her cabinet for some silverware, and she fell. She fell down. What kinds of things are you going to be wanting to kind of know and prepare ahead of time when you get this call?
So just like we talked about the train van, as soon as she fell, hit her head, likely what's her chief complaint? What's her mental status when you walk in? Was any witnesses that she loses consciousness? Meds.
Good.
Kind of look at that and do a set of vitals, go from there.
Awesome.
We're going to, we'll mobilize her, we're going to talk about that in 55.
All right, so you assess your patient. She's on the ground. She's been there for about 22 minutes. She called for help. Her chief complaint is back pain. And one of the things that she tells you is she has to pee really bad, but feels like she can't. Okay? All right. Are we good with resources? Are you happy with an engine crew and your ambulance crew? All right.
Yeah, one patient, yes.
All right. Awesome. This is your primary assessment on the patient. Phase is normal. You notice that she is tachypnic. She does have a nice, strong radial pulse. She's awake and alert. She can tell you everything that happened. She tells you that she was a klutz and this shouldn't have happened, and she feels really bad for calling you. And then as you move on down, looking at her lower extremities, you notice there's some blood in her pants. Okay. All right. Do you want to immobilize that patient?
Yes.
Okay. She does complain of back pain. She is over the age of 65. You can't talk yourself reasonably out of immobilizing this patient. I fully agree with you. You want some vital signs?
Sure, absolutely.
Here we go. Little on the tachycardic side. Blood pressure leaves something to be desired. Definitely tachypnic. End-tidal CO2 on the low side, but otherwise normal. Got a glucose. GCS is just fine. What worries you about what you're seeing?
So I look at her med list, see, so pressure stands out to me, 96 over 62 there.
Okay.
She's obviously in some stress, tachypnic. Temperature's 96.9.
Okay.
But I'd say blood pressure, and she's tapping, so we talked about with the cardiac output.
Absolutely. Now, let me ask you this. What is her maximum heart rate? Like, what is the maximum expected heart rate for a 77-year-old? Anybody remember kind of the formula? 200 minus age. So her maximum heart rate, in theory, should be 123. She is at 109. What kinds of reasons? You know, she's definitely trying to perfuse very low here, okay, for whatever reason. So therefore, we would expect her heart rate actually to be closer to the 110s, even 120s, if she's really that sick. So what kinds of things can drive that heart rate the way it is?
Beta blocker.
Beta blockers, for sure. Any other ones? Calcium channel blockers, for sure. What do you want to do based on what you're seeing?
We'll get a line. Where are you going to? Pretty quick. Could be some pelvis, bladder, to on what she hit. And I assume she fell like on tile or carpet.
Yeah, it was
So,
the
yeah.
kitchen floor, so it was
That'd be
definitely
hard
just
to
tile.
purchase,
Do you give her fluids?
What's that map come out to? Map over, as long as map's over 65, yeah, I would definitely get access.
Okay, so fluids or no fluids?
Yeah.
Whenever in doubt,
Yeah.
she does have a radial pulse. Okay?
She's good.
Yeah, she's maintaining fine. She's perfusing here well, and she's got a radial pulse. Remember, in a really bad day, and your fancy monitor is not working, you're not getting a good map, and you don't remember the calculation, that's fine. You can probably leave this alone. We'll hit all of this, I promise. Okay, all right. Now, this is her medical history right here. Remember, we have a last oral intake. Last menstrual period really doesn't apply, though these days you never know anymore with in vitro and crazy things that people do. But a 77-year-old, I would probably worry about a last menstrual period. She is indeed on verapamil. Anybody remember what class of meds that is? Calcium channel blocker, 100%. So now we have a really good reason to see that heart rate down. And now I'm more worried. Now I'm actually a lot more worried because remember, we talked about we have a 77-year-old expected heart rate of 123. It's 109. In reality, this lady's probably should be a lot more tachycardic. She is beta blocked, and so she's trying to compensate for some very significant stroke volume reduction. She's bleeding somewhere, right? Okay.
Was her blood in her pants or whatever, is that from an external wound, like a laceration, or did that come from her?
I'll give you some other exam findings. How about that? Here we go. Head is okay. Cervical spine, no tenderness, but you have immobilized the patient. You look at the chest wall, equal breath sounds. Heart is good. When you come to the abdomen is non-tender. As you're looking down, once again, you notice blood on her pants. When you take down the pants, then you notice there is a laceration right in the perineum. Okay? It's about 3 inches long. Just kind of right in the groin. Okay? It's a very small amount of oozing that is continuous. All right? What are the two indications, again, in the field for actually doing a GU exam in women, particularly? There's only two. One, trauma with bleeding. Yeah, trauma with bleeding. And two, women pregnant and crowding. Yeah, absolutely, 100%. Okay, so what do you guys think now? What's wrong with this lady? Yeah, she's sick for sure. Where's she bleeding from?
Can that be from a pelvis fracture?
That's very high in my differential diagnosis. Let's talk about that. Okay. We talked about exam findings, okay? Now, a lot of us in this room, including myself, Paul, we talk about pelvic rock. We practice in a national registry, and if you didn't do it, you failed, and if you didn't do it, you're a heretic, and you're a bad, bad medic, okay? On the other side, there were people saying, you know what, I wonder if we're actually making things worse by doing a pelvic rock on people, all right? Well, guess what? These heretics, they were actually right, all right? Pelvic rock is completely useless in the assessment. It's not very sensitive or specific in the detection of pelvic trauma, pelvic fractures, pelvic instability. If anything, we were causing a lot more pain in making these injuries worse, okay? So now what I would like to teach you today is that we have to rely on two things. One is your mechanism of injury in a 77-year-old off a step stool who falls. That's suspicious enough. Two, I want to teach you some visual exam findings. Any discoloration or complaints, lacerations, bleeding in the genital area that you can't explain for any other reason in the setting of trauma like that is a pelvic injury until proven otherwise. Okay? Now, something else that's very interesting in here is the unexplained urinary symptoms. All right? So all of a sudden, you have a mechanism, you may or may not have visual findings that you can actually see, but if a patient tells you anything related to their groin or especially urinary symptoms, that patient has a pelvic fracture, okay? We also used to teach you about looking for blood coming out of the pee hole, out of the meatus. That's a bunch of crap. I've only seen that really a couple of times in my career. What I do see more often with pelvic fractures is grandma saying, I really gotta go pee so bad, but I just peed like 5 minutes ago. It feels really weird, like my bladder is full, okay? That is injury to those pudendal nerves down there that supply sensation to our bladder and our genitals, etc. That should cue you in that there's a pelvic fracture, okay? Now, let's say that you are a go-getter and you absolutely want to put your hands on that patient. You want to examine. Anybody know what, we already got a mechanism, we got some visual. What if we really wanted to touch, palpate? What's the best way? Anybody know? All right, the best way to examine a pelvis, ladies and gentlemen, is very simple. We look for the trochanters. That's the widest part of our hips. Trochanters is kind of the ball where the femur attaches to our hip joint. We want to palpate that, okay? We can compress one side versus the other and push. Patient says, ow, that is a pelvic injury as well. May have nothing else, I palpate the trochanters. It may also be a femoral fracture, but if you absolutely want to examine your patient to be thorough, simple palpation, light palpation at the trochanters is a good exam finding that you should be aware of. Okay? But do pay attention to the mechanism, urinary symptoms, and definitely visual findings, discoloration, bleeding, or oozing. So what is this? What injury does this patient have again?
Pelvic fracture.
He's got a pelvic fracture. All right. Anything else that you want to add to your? We got a line started. Got a cervical collar in place. We're hauling butt to where are we going with this patient?
MCP.
MCP. Okay, cool. Anything else you want to do?
Stabilize the pelvis.
How do you want to do that? Sam splint.
So we have the what we call a sut splint. It's a full body, full body air splint, long forward.
Yeah.
That would be enough to, assuming you get up tight, maybe.
Okay. Very cool. Let me ask you a stupid question. Do we backboard this patient as well, or just use our big full body air splint? Okay. Cool. Do we foresee the day where we're just gonna get rid of backboards and toss them in the trash? Probably. Anybody know really kind of what's the big reason? It helps us a lot get patients to and fro.
It's not comfortable and it doesn't know how to do
Yeah. Anybody know what the long-term damage is from backboards? Sacral ulcers. Okay? Bad ulcers. As little as 1 hour of backboard places enough pressure on our sacrum to create bad wounds. So within 48 hours, you start noticing some bruising here. Next day after that, there's a little bit of breakdown there, and then the patient walks around with a really horrendous wound back there. Ladies and gents, we will see the day very soon when backboards are going to be a thing of the past, and we're going to be moving forward to better solutions for immobilization and transport like the full body splints. All right? Now, somebody mentioned stabilizing the pelvis. We're going to discuss this in our next case, but I want you to know, love, and love even more your pelvic binders. We're going to discuss the application here shortly. All right? Just to remind you some of the BLS interventions, we have a good SpO2 and a good end-tidal CO2 on this patient. We don't need supplemental oxygen. We don't need to be in an on rebreather. Hyperoxia is bad. Focus on your end-tidal CO2. All right, a POC glucose is fine. We don't know if grandma was really a klutz or she had an episode of hypoglycemia. We really don't know. A POC glucose is fine. Remember, your sample history should focus on medication, particularly on your DOACs, the Tran, the bands, and then your classic ones like Plavix, aspirin, okay? And then in else, your last oral intake is really all I need for a last menstrual period in a woman of childbearing age. That's it, okay? Now, when it comes to ALS interventions, we discussed this lady really doesn't need IV fluids. Her MAP is fine, it's close, it's borderline, but she's mentating fine with a good strong radial pulse. I promise you, we will discuss the true rationale for that, okay? If we do, however, need that, I will reemphasize 10 mLs per kg. You can repeat that up to 2 times only if needed, and we go to our preferred trauma center as needed, all right? So summary for this point. Number 1, the signs and symptoms for a pelvic injury can be very impressive or they can be very subtle. You really got to be looking out for it. To me, it's all about the mechanism. It's about the subtlety. Don't rely on pelvic rock to say yay or nay. All right? And a few other key points. Remember, we discussed the DOACs, Tran, the band, and the band. However, you are still going to see some of the older ones, like heparin, patients who give themselves, Xaparin or Lovenox injections in their belly, those with DVTs, for example. And also you want to be aware of some of the older ones, like clopidogrel, which is Plavix. That's very common in patients with heart disease. But the modern medic should recognize, at the very least, these 3 DOACs and recognize patients with that in a source of bleeding are going to bleed and bleed and bleed and bleed and bleed some more. All right, now I'm going to take somebody to lunch next time if they can answer a question for me. All right, this is just for fun. Does anybody know? Let's take the bigger trend. Does anybody know how we reverse some of these? Pradaxa is the bigger trend. Anybody know how we reverse some of these DOACs? Let's say you get called to Legacy ER and they're like, I don't know what the hell, I don't know what to do. Okay, that's a great option. All right. Now vitamin K is really good for warfarin and warfarin only. All right. For the modern medic, if you happen to run to Legacy and they don't know what they're doing, and they might, there's a reversal agent. It's called Praxbind. All right. They might request that transport a dose of Praxbind for these patients. For rivaroxaban and apixaban, dialysis is really the only way to get rid of them. So whenever patients come in with bad hemorrhage, such as this one, and they're on a DOAC like that, they either need a reversal agent like Praxbind, or we dialyze them sometimes. All right, so that's just for fun, just some additional knowledge for you. And now we'll move on to round 3. We are moving right along. Okay. We don't have a lot of nightclubs here in Allen, do we?
Oh, yeah,
We used to.
strip clubs.
We got the Bethany Tavern.
Yeah.
Where is that?
Right over there off on East Bethany, right there.
30 roofs behind
Starbucks.
Yes. Paul was asking like where you can go drink afterwards. And he's like,
You can go
what's
down
that
to
one?
Water Street.
Get a few beverages.
Doty's.
some beverages. I like that. All right, Mr. Gibson, we get a shooting outside of a local watering hole. PD is already en route. We got one unit over there. Anything else you want as far as resources or anticipation for that scene?
Yeah.
But binoculars.
All right, you have been cleared to go in. We're not going to enter that under any circumstances till we're good to go. Okay. Now, once you do find your patient, you have a patient in the parking lot. You have a volunteer firefighter on scene. He's putting pressure on abdominal wound. Okay. What else you want to know about this gentleman? It's a gunshot. It's a GSW. Yeah. All right. Small caliber handgun.
I know you don't know much about guns, they come
They're
Yep.
all assault rifles.
Or assault rifle.
Where's Durant?
Go
Have
back.
like 300. I mean, what are we talking?
So the man got shot with a 40 caliber handgun one time by unknown assailant, minding his own business, of course, as always, right? We look in his mouth. There is no airway trauma in the mouth. He is tachypnic, but he's not in significant respiratory distress. We check a pulse. There is a pulse, but you're having a hard time feeling a pulse. Remember, capillary refill is pretty useless in the field. You notice that he is cool to touch. He is alert and awake and talking to you. Okay? We have a single wound. Remember, we don't call them exit or entry. We don't care. That's for the medical examiner, forensics, or the nice doctors at the hospital to determine. Single wound to the left upper quadrant. Now what, Mr. Gibson?
Oh, but fluids, for sure.
I'm sorry, Mr. West. I apologize. Sorry, man. That's my bad.
I'll do that.
We want to get an idea, you know, before getting him some fluids, see how his mental status is,
Okay.
decide if we're going to have to take over his airway, if he can't protect it or not.
Very cool. Very cool. Let me ask you this. Do you immobilize this patient's cervical spine?
Do we immobilize it?
Yeah. Let's get a show of
What kind of
hands.
position? Where's he at?
Injury, I guess it just depends on.
I would say no.
No? All right. Let's take some votes. How about yay? I want to immobilize cervical spine.
Seeing a hard spot to get to, how big is this dude?
He's in a parking lot. He's a big dude.
A big dude?
Yeah.
Maybe if he can't get up and stuff, maybe just get him on one to get him on the cot and roll him on the cot rather than that.
Okay, cool. So do we have any definite yays?
You never know where that bullet went.
Okay.
You know,
I'm gonna say do it.
Do it? Okay. The group is looking a lot more committed to yes. The last group, pretty much everybody, except maybe one, wanted to immobilize. So let's discuss that for a second because it's very pertinent. Pretty much just like pelvic rock, immobilizing the cervical spine, no matter what, is something that we get taught. If any ever in doubt, immobilize. Now let me kind of change the mechanism a little bit. What if he was shot right here in the head? No? Do we still immobilize?
No.
Not a big problem? Okay.
Look at the bigger picture.
Look at the bigger picture.
Right.
I like that. Okay. So we've come around, ladies and gents. Very, very, very few of patients with penetrating trauma, even to the head, actually have an accompanying cervical spine fracture. Even though we don't know really where the bullet went, we studied this over the years, and the incidence, the number of cervical spine fractures is actually remarkably low. If anything, we are creating an upper airway obstruction for the patients. We make their ventilation worse. We make our airway maneuvers and monitoring even more difficult. So now we're going the opposite way. It's like we better have a good reason to immobilize the patient, believe it or not. When Paul was going through medic school and practicing, even to this day, we would probably consider immobilizing this patient's cervical spine. All right, but I do agree with Mr. West. We're going to put a line in him. Does he need fluids?
Yes.
Okay. Yeah, remember, he is maintaining fine, but we discussed a radial pulse is a good way. What should a blood pressure be if we have a radial pulse around? 80 to 90. Okay, if we don't have a good, strong radial pulse, even for a big dude, we gotta consider that they're hypovolemic. Our stroke volume is probably down. I would expect that your next request of me would be vital signs. I'll give you some vital signs. All right. He's definitely more tachycardic than our other two cases. Definitely hypotensive. Definitely tachypnic. SpO2 is 92%. End-tidal is on the low side. We really don't need a blood glucose. On this gentleman, we get a GCS of 14. All right. So remember, going back to our formula, our heart rate is way up. We got an abdominal wound somewhere. We're losing stroke volume somewhere. All right, that's a sick person. All right, very cool. Let me ask you this. How much fluid again do you want to give him? Just titrate it up, or how much?
10 cc per kilo.
10 mLs per kg? I like that. All right, what do you want to do about his SpO2? Concerned, not concerned?
It's getting to the lower side.
Okay, put him on an arm breather. Okay, I like that. What do you think of his end-tidal CO2?
Low.
Well, you can see tachypnic, right? So we know he's ventilating well. You might want to consider doing some supplemental oxygen if you need to, but he is ventilating just fine. All right? Okay, giving you a little more sample history. He is not on any beta blockers. He's not on any DOACs. He's not on a calcium channel blocker. We were very nice in asking last oral intake, and he tells you he had a steady diet of beer. Very, very healthy. Okay? And he tells you that somebody was firing shots. He got struck in the car. Where are we going with this patient?
MCP.
MCP? Okay. I respect that. We go to a secondary assessment. Pretty unremarkable, but we do have a single wound to the left upper quadrant. There is diffuse tenderness. In our initial case of trauma to the abdomen, tenderness or pain equals what?
I believe.
Hemorrhage. Yeah, absolutely. 100%. Till proven otherwise. He is diaphoretic. All right. So what do you think is wrong with this patient again?
Gunshot.
Gunshot. Okay, good. Causing
Bleed.
hemorrhage. Okay. Now, just with this, if I never saw the patient, never laid eyes on the patient, I have one diagnosis for sure. One. Even if I knew nothing else other than left upper quadrant wound with this, what diagnosis do I have? Maybe. It could be anywhere, right? I know one thing for sure. Close. This patient, ladies and gents, has shock. We know this is shock, 100%. What is the likely type of shock that we have? Hypovolemic, hemorrhagic. Okay, good. Could he have any other types of shock? What would be the second most common for him? Left upper quadrant wounds. What if it traversed past his diaphragm and now punctured his left lung? Excellent. Okay. So the next lesson I want you to remember: in penetrating and blunt trauma, tachycardia equals shock, UPO, till proven otherwise, each and every time. Sure, they might be in pain. Sure, they may be anxious. Sure, they may be on drugs. But when you have a patient like this, your mind should go directly to, I have a patient in shock. I need to determine what kind it is, and I need to know what to do with it. All right? When we were discussing when we were discussing Paul's picture over there, one of the things we've learned over the years and emphasized on July 7th, how did most of the officers from July 7th get to the hospital?
Police car.
Police, yeah, police all the way. All right, I think one or two went by EMS, the majority went by police. And even though those officers didn't survive, it really emphasized something for us at the kind of the EMS level, is that minimal interventions, minimal time on scene is actually life-saving. And we've studied this. The more time you spend on scene in a patient with hemorrhagic shock, the worse they're going to do. Why? Because these patients really need two things. One, they need hemorrhage control. Either they need a tourniquet, or they need wound packing, or they need an operating room. And two, they need blood. Those are the only two things that are going to make any difference whatsoever in a patient with hemorrhagic shock. That's what we emphasize, minimal scene intervention. All right? Now, we discussed a little bit of volume, and your department is very progressive in minimizing the amount of volume. Why? We know dilutional coagulopathy, diluting all our clotting factors. One of the bigger reasons why minimal fluids and as little as possible on scene is something called permissive hypotension. Okay? So basically, the days of wanting a patient to be in the 120/80 range, no matter what, those days are gone. Let's talk a little bit about why. Let's take the aorta, for example. I got a laceration because of a knife or a bullet traversing the aorta. So now we have a big fat vessel, we have a big tear through it. When we have a normal blood pressure, the force, the shear force on that aortic wall is very high. They're designed to handle high pressures. When there's an injury to it, a normal pressure actually prevents clotting factors in that wound from naturally sealing. We are actually very good clotters, very good healers. What we learned over the years is that minimizing the pressure through that aortic wall, through that injury, actually saves lives. That allows that force on the aortic wall to be lower and lower so that the wound has a chance to clot on its own. So now it's actually fairly healthy to allow these patients to be somewhat hypotensive. We don't have to get them to 120/80. We were killing patients. So Paul's patient over there probably had a bad vessel injury, may have had obstructive shock too, but if you remember the picture, there's somebody holding a bag and they're doing this to the bag, trying to get them to 120/80. Well, guess what? That wound kept bleeding and bleeding and bleeding. That gentleman is in a cemetery somewhere. Okay? All right. Now, we discussed the two things that are going to save a patient's life. One is hemorrhage control. The second one is blood. All right? The modern paramedic is going to know and love whole blood. There are some systems that are carrying blood right now, such as San Antonio Fire Department. Some of our helicopter services have it. And this is a good way of giving patients the red blood cells that they're losing, that stroke volume, but whole blood also contains all the clotting factors that you're losing through blood, and you are avoiding that coagulopathy that these patients suffer from. All right? Okay. We wanted to give the patient a little bit of oxygen. We're going to titrate our fluids up. He doesn't really need a POC glucose analysis. We got an ample history. We gave fluids as we mentioned, and we're going to take this patient up to MCP as we mentioned. All right? Now, just to reemphasize this note, a normal BP is actually killing our patients. Let's practice some permissive hypotension. All right? Titrate only to our radial pulse, nothing higher. They don't need to be 120/80. They need hemorrhage control, and they need blood. All right?
So you're saying the 2 IVs and large bore kind of be
So
minimal?
basically just giving them the amount of fluid he needs to have.
Yeah.
Decent radial pulse.
Yeah, pretty much if you want to do 2 in the back of an ambulance where you're hauling blood, absolutely. But to be quite frank with you, the only reason to start a second one is for them to get to the hospital, and they need blood products and platelets, a massive transfusion protocol. That's really the only reason for 2 IVs, in my humble opinion. Otherwise, in the field, we just need 1. Okay? All right, let's discuss sexy TXA. Anybody heard of this? TXA?
Volume expander?
What's that?
Is that a volume expander?
Close. So what this does, when we have bad hemorrhagic shock, we undergo something that's called fibrinolysis. Fibrin is a natural kind of clotting mesh that we develop in those vessels that we discuss that help us clot. In very bad shock, all of these clotting factors go to crap. Not only do we dilute them, but the shock itself, as they're becoming more acidotic, etc., that fibrin goes to crap. They begin to break that fibrin, and patients bleed and bleed and bleed some more. Okay? Officer Mike Smith, one of the July 7th DPD officers, came into our hospital awake and alert. Okay? Took him to the operating room. He had a left flank wound with a rifle. When he went to the operating room, everybody was doing the right thing. All of a sudden, he began to kind of bleed. Instead of blood, it was Kool-Aid. It was pink, clear stuff. Okay? So at that moment, everybody knew that Mike Smith was not going to make it. Why? Because we knew that his fibrinolysis was so severe that everything became leaky. He no longer had a mesh. He no longer had the capacity to clot. And everything was oozing out. All the fluids we were giving, all that stuff, all the blood was just oozing out. All right? So now what TXA does, it's a wonderful little drug. It actually prevents the breakdown of fibrin in patients with hemorrhagic shock. Okay? So this is something that your department is going to be looking at, I think and I hope, eventually for patients with bad hemorrhagic shock. Okay? It's been known to save lives. It's not perfect. In patients with advanced fibrinolysis like Mike Smith had, this would not have made any difference whatsoever. But in patients with early decompensated shock, TXA can be a wonderful adjunct to hemorrhage control and blood. All right, so there's one more thing to help patients survive these types of injuries. Okay? Any questions on whole blood, permissive hypotension, or TXA? Key summary points. Remember your formula and think to yourself, tachycardia equals shock until proven otherwise. Remember that permissive hypotension, it's perfectly okay. One line is perfectly okay with me. One bolus titrated up to a radial pulse. Blood is going to be carried at some point, maybe perhaps by an advanced practice paramedic in your system. That's what I would foresee for you, for example. And then also consideration to TXA in patients with advanced fibrinolysis from hemorrhagic shock. Okay?
I know we don't carry it, but how fast can you pump blood in?
Pretty fast. Just to give you an example, in the hospital, when we do a massive transfusion protocol, we have a cooler of things, and we pump cryoprecipitate, platelets, and packed red blood cells. We do it through preferably 2 IV lines or a central line, and those can go in very, very quickly. Patients can become volume overloaded from that, but that is the very least of our concerns. These things can go in very quickly, just like a bolus of fluids. Yep. There's some issues with carrying whole blood, for example. In a city as beautiful as yours and relatively quiet, I guess, whole blood would probably go unused, and blood is expensive. So there are some downsides to it. But in a system where you may run into quite a bit of hemorrhagic shock, either penetrating or blunt, it's the way to go. Okay. Very good. We're moving right along. Mr. Patrick, can you do the honors for us on this one?
Yes, sir.
Thank you. Got a good old MCC. Anybody own a motorcycle here? No? All right. I don't want to make it disparaging comments. Okay, cool. So, you have a young woman who is under a vehicle after an MCC. We mentioned the kinds of resources that you wanted on a busy side street. What else do you want to know about this patient?
I want to make sure she's still breathing, her A&O status. Look for any deformities, she's preparing the car, make sure there's not any fluids leaking underneath there. And, possible potential fire. You would have to do a rapid extrication to get her out from underneath there. So, and then most important, make sure she's wearing a helmet.
Okay.
And assess her breathing and check for relevant and pulses. Just make sure.
Cool. Speaking of, how do you personally, or how does your department do helmets? For example, say you find me and I'm wearing a helmet. It's a shielded helmet. How do you work through it?
For airway. So, typically we would pad underneath the shoulders, kind of get in a neutral position, have somebody hold the neck, and then have another individual kind of rotate the helmet off gently, and then check the cervical, and then immediately apply CPR.
Okay, very good.
Could we leave in place of last breathing compromise?
Sure. That you can.
You can. You absolutely can. I'll take some votes. Do I, as a physician, have additional training on helmet removal? Average physician? Nah, I don't get any training. I do because of my EMS work, but an average physician working in a hospital doesn't have additional skills on helmet assessment. You guys are actually the experts in helmets, okay? So don't let anybody push you around when it comes to helmets. You guys know more about helmets than most people do. Okay, all right. We got a pretty sick lady, but she's wearing her helmet. The second vehicle is fine, got some front end damage, nothing to worry about. I'm going to give you a primary assessment for this patient. You take off the shield. There's no blood trauma to the airway. Respiratory rate is increasing. No distress whatsoever. She's got a good strong radial pulse. She is talking to you, and she's got bad road rash of the left thigh. Does this patient need a cervical spine immobilization? Why or why not?
She climbed in the car, had road rash, so she most likely she will have damage to the helmet, which could have, compromised her cervical spine.
Very cool. Does she have a distracting injury?
Yeah, the road rash.
Excellent. Yeah, so right off the bat, you got bad mechanism, you got a distracting injury. She's really not complaining of neck pain. That's a patient I'm going to immobilize for the reasons that you mentioned. Okay? All right, so we'll put a cervical collar in place. I assume you would love see some vital signs?
Yes, we'll do a detailed head to see if we have any other formulas going on.
Yeah.
Make sure all this is good.
I'll give this to you. All right, definitely tachycardic, soft pressure. Now somebody might argue, well, she's 28, she might not be far from her baseline. Duly noted. So knowing what we know now, what should we say to those folks?
We're suspecting shock or hemorrhagic.
Yeah.
So
Outstanding.
already have her immobilized. We'll get an IV established.
Okay.
Give her some pain medication, ketamine,
Good.
fentanyl combo, Zofran for any nausea or anything like that.
Good.
And then get her into the back ambulance, get her away from the hot pavement in a hot car.
Good.
We can cool her down, her temperature's a little elevated. And then we get fluids, 10 mils per kilogram.
She need fluids?
Keep her warm. She has a strong radial. Technically, she does not, but we just have not yet established her radial.
Yeah, I would agree with that. You happen to remember your dose for ketamine or trauma?
Pain management, 0.1, 0.2.
Good.
Kilogram.
Good. So low dose ketamine for pain is much lower than the dissociative dose that is much higher, 0.4 to 0.5. Okay, great. Absolutely. And good job of recognizing tachycardia no matter what the blood pressure is. Somebody may say, it's just not far from her baseline. Yeah, that's cool and everything, but don't forget your formula. Okay, good. All right, so I'll give you a more detailed physical exam, or a sample history, I'm sorry. What L did we miss on this patient, by the way?
Your last initial result.
Excellent. All right, so we got a last oral intake. She doesn't take any DOACs or any antihypertensives that we know. She's got no past medical history. And she tells you she unfortunately ran a red light and she hit another vehicle that kind of went in the other direction. So that's really bad. Now let's remember, she is now pinned under there, okay? So as you're doing everything that you're doing and doing so correctly, you get a physical exam on her, and that's really remarkable only for kind of tire tracks along her flank and in her abdomen. You do see the rash on the thigh that we mentioned, and a deformity to the right foot. It looks closed. Her GCS is 15. All right, cool. What injuries do you suspect might be present in this patient? We do suspect shock. What kinds of injuries would worry you? Pelvis for sure, yeah, 100%. We don't really have any other sores, so I would be concerned about the abdomen. Pelvis for sure. Don't forget about obstructive shock, somebody with that level trauma. I don't have a lot of suspicion for neurogenic shock or intracranial issue, so I'm going to be focusing on the abdomen and pelvis. All right, we discussed BLS. Does this patient need a binder?
Absolutely.
I would say yes. She had a vehicle run over her pelvis, so
Yeah.
just for stability.
Could that be a source of what you're seeing there, loss of stroke volume? Yeah, okay, it absolutely could. We got a good sample history. Don't necessarily need a POC glucose, all right? However, the moment we extricate her, the patient, her eyes go glassy, she becomes unresponsive, and you lose pulses. So you start CPR. Dang, now what?
Calcium bicarb.
So bingo, calcium chloride,
Okay,
following Epi.
very cool. Now let's say you had every tool, including tools provided to you hypothetically in this lecture. What would you consider giving this lady?
Blood.
Yeah, that'd be a good adjunct. Good, absolutely. TXA?
Sure.
Yeah, absolutely. These are real life cases, by the way. The victim in this case, she wasn't a motorcycle. We wanted to make it a little more, little sexier, I guess. But the driver of this vehicle, I'll never forget it, right off of Stemmons. She was in a little BMW, older model. Somebody hit her. She spun out. She rolled over. She was pinned under the steering column, and it took forever to get it out. Everybody did the right thing. The moment she got extricated, ladies and gents, I'll never forget her eyes. It just went kind of glassy, kind of looking off. I'm like, oh crap. She lost pulses. We were never able to get her back. Okay. So what strikes you from that case? What strikes you about that? When we extricated her, she loses pulses.
Acidotic.
There was tamponade in the lead, and then you took it off.
Yeah, she had a bad pelvic injury. Okay, so the reason I put pelvic binders on there is, had we known what we know now, remember pelvic binders for a while, just like tourniquets. They received some attention, then they went away, then we started focusing on using sheets or whatnot. So they made a big comeback now. If we knew what we know now about pelvic binders, what we would have done is actually do everything that you talked about. Put a cervical collar in place, start a line, give her a little something for pain, and then we would have at the very least kind of gotten the binder around her and ready to rock and roll, and coordinated so that the moment we got her out, we could have tightened that baby up and known that the moment we released her, well, that pelvic volume was going to be lost. So I wonder if this could have saved your life. I'll never know, but it's really sad that if I knew what I know now, she might be alive, and that hurts. Okay, so go ahead.
We have somebody that's been like that, we're gonna want to pre-medicate anyways with sodium bicarb or calcium chloride, not in the same IV, but we're wanting to, just because we know that's going to happen, we have to prevent that. And your previous history, do you know if that stuff even truly prevents any of that, or
You're probably referring to rhabdomyolysis, the release of myoglobin after somebody has a crush injury.
Could you really pinpoint that was her problem though, with just the steering column on her?
Yeah, so she was on her side, kind of wedged between the seat and basically the ground. There was some debris under her, and she was pinned like right here. And we didn't recognize it. We thought, okay, she's definitely tachycardic, definitely hypotensive, could be something in the belly. It just never freaking occurred to me or anybody on scene that really what we were seeing is she had a compressed pelvis. Okay, so basically what happens, our pelvis is a very tight environment, so tight that it's very hard to access even during an operation. Okay, so if I have to open you up for whatever reason, I can't open far enough to get to the pelvis. The only way we can actually tamponade pelvic vessels that are bleeding, it's a big collection of vessels. This actually go through the groin or the radial artery and do an interventional radiology procedure to clot off those blood vessels. That's how hard it is to access. Okay, and they're so tightly packed and so numerous in there that the moment you disrupt that with a pelvic fracture, they bleed and they bleed and they bleed and they bleed some more. Okay, so by putting on a pelvic binder, we close that volume down, we close the volume of that pelvis, we naturally tamponade those bleeding vessels. So yeah, for this poor lady, she was being compressed by the ground, and the steering column, that was her pelvic binder. The moment we yanked her off, there's nothing that we could have done to stop the bleeding once it started. You just can't.
Could have you gotten that in there ahead of time?
That's what we were wondering, kind of in retrospect. We should have put a binder. We didn't have binders at the time.
But with her in there, you could have swung that around her hip and got it binded.
Yeah, we never thought of it. We were so worried. Yeah, we were so worried about everything else and traffic going by. We never thought about it. What Mr. Patrick is referring to is kind of crush injury. One of the things about bicarbonate, they really help in patients who've been pinned for more than 3 to 4 hours. The release of myoglobin for something that you're going to see is not significant enough to warrant. Now, what bicarbonate will do for you is it will increase your end-tidal CO2, kind of driving your pH a little bit off, which could actually be detrimental. So the only time that I use bicarbonate now is, say, for example, a construction worker that's been pinned for 4 or 5 hours, search and rescue, has to bring heavy equipment and get him out, then I'll consider it for. But for pelvic trauma like this, even with an extrication time of less than an hour, I'll probably defer it. Okay? If this lady goes into cardiac arrest, yeah, you can do definitely ACLS, but definitely will need blood and get to the hospital as quick as you can. All right, cool. When do we apply a pelvic binder? We discussed that pelvic injuries can be simply a matter of you suspecting it. It can be a visual finding, or it can be present in very mild palpation of the pelvis. If you have any or all of those, put a pelvic binder in place. The only contraindication in the past was if a patient has an accompanying femur or hip fracture. Okay, I hate the word hip because it confuses people. If the only contraindication in the past to a pelvic binder was if you have an accompanying femur fracture, that's going away. If you suspect a pelvic fracture, either suspect or confirmed, put it on. No harm. It'll hurt. That's why we have wonderful pain medications to do that, but it can literally save their lives. All right? How do we apply a pelvic binder? When I put one of these on, I strap it. Where's the biggest center of force? Where should this be? All right, the biggest, we apply this so that it's right at the trochanters, right at the junction right here, the widest part of the hip. So we got our iliac crest sits kind of high right here. Our trochanters are just kind of a finger length away. That should be the maximum compression site. I see them applied sometimes way too low, sometimes really high up here in the abdomen. And they really should be, maximum force should be right at the trochanters. That's where you want to tighten that baby up as best as you can and as hard as you can, and warn your patients that you're going to do it. All right? So remember, not a butt binder. We're not putting it on the butt. We're not putting it on the legs. It's not a belly binder. It's right on the pelvis. Trochanters are your biggest point of pressure with this. All right. This comes from the military. It's a summary of basically exactly what I talked to you about. It's a matter of suspicion, visual findings, or tactile findings. So low threshold to put it in, just put it in. There's no harm. Nobody will chew you out for it. If you suspect the patient has a pelvic injury, go ahead and put it in. All right? If you don't have it, then blankets are fine. Tighten it up, but you guys are blessed and very progressive to carry these. All right? What are we doing on time? Good. Once it's on, ladies and gents, it shouldn't come off just like a tourniquet. The only indication to take it off is if you have to address life-threatening hemorrhage, like a femoral vessel injury, for example, and they're bleeding, then you can take it off and put pressure on that bad boy. All right? Okay, we're almost there. Almost there. I'm going to get you out of here no later than 4. Mr. Raymer, can you do this one for us? Sure. Thank you. Okay. We got us a millennial on a skateboard. All right? We got 14 years old. Out of curiosity, where do 14-year-olds go around here?
That seems to change weekly.
Yeah, it really does. If they're really hurt, trauma, where do they go?
Parkland.
What if it's just like a minor kind of deal?
Let's see,
Wheezing, bronchoconstriction, or
let's see that was for what?
like bronchiolitis.
You went trauma with
Non-trauma stuff in let's see.
Okay, very cool. So you get called to a scene where a 14-year-old skater, a skateboarder, fell, and they called 911. Okay? He is on the ground. Some minutes off. He's got his other protective gear in place. You do a primary assessment on this patient, and you got no airway findings. He's tachypnic. We got nice radial pulse. He's awake and alert, and no outward signs of trauma, no bleeding anywhere else. Paul, can you tell me right quick about your elbow injuries?
So, usually, right, let's rate this as a distracting injuries. So, let's just have that left. When I was now 20, she was much smaller at this age. So we were, it was after Thanksgiving. You guys know that it gets really dark early. And so my daughter's like, Dad, let's take the dog for a walk. And I was like, okay, let's take the dog for a walk. So we take the dog for a walk. She took her Razor scooter, okay? And so you guys know, if you've seen these Razor scooters, the wheels are probably about 3-4 inches tall. And so through this walk, she's saying, Dad, ride my scooter. Dad, ride my scooter, ride my scooter. I was not doing it. So finally, we get to the top of a hill, and I'm like, this is the time to ride the scooter. So we're at the top of this hill. I'm on the scooter. She's pushing me, so we've got some speed going on. The dog's galloping, trying to keep up with us and all that stuff. And so I'm on the sidewalk, and so there's a driveway, and the sidewalk, poured at different times. The sidewalk had settled 3-4 inches, right? And so we're coming down this hill, down the sidewalk, and the scooter stops. Never saw it because it was dark. Never saw it. And so next thing you know, I'm flying through the air like Superman. And I put my arms out to break the fall. And I land, hit the concrete, and I knew right away that I had messed up this arm really bad. Because, I mean, it was some serious pain. So what happened is I had a fracture, radius ulna, and a dislocated elbow. And so I get up, I held it like this, and it hurt so bad. I mean, you get that hot rush, you get the numbness and the tingling and lightheaded and feeling like you want to puke and all that kind of stuff. So I was like, man, I gotta sit down. So I sit down on the curb. There's cars going by. I thought, oh great, I'm about to get ran over by a car on top of everything else. So I went to push myself up. So I reached down with this arm to push myself up, and then I realized, oh, something's going on over here too. And so ended up that broke radius ulna as well over here. And so I walked back to my house, both arms splinted like this, and I go inside the house. My daughter's with me. She's opening doors, carrying the dog and all that kind of stuff. And so I call my wife, and she's at the gym, not answering her phone. So I called my sister, and then they took me to Bailey Grapevine, and it was really messed up. And they said, yeah, we need to get a CAT scan of that. The X-rays were not good enough. And so got to find out that my wife loves me a lot, because she did everything for me for about 4 weeks. I couldn't drive, I couldn't bite my tail, I could get a finger right under there to pee, but that was about the extent of what I could do. And so I had to do everything I was strong because I couldn't lift a cup, because I had to bend over, eat food off of a plate that was already cut up like a dog, so just a bad time. So my illustration is that this arm hurt so bad. I had 2 fractures over here, didn't even know it until I put weight on it. So
True distracting injury, for sure. All right, cool. We have a young 14-year-old, heart rate of 120, blood pressure pretty adequate, elevated respiratory rates, entitled CO2 is low, likely because, yeah, exactly. Glucose is fine. What do you want to do with this one, Mr. Raymond?
I want to know why I'm here first. I don't know what happened or.
All right, so he's on the ground, tells you he hit the rail, struck it on the rail, right on the abdomen when he was doing a crazy stunt, and now he's on the ground. Yeah. Yeah, he's got like 2 buddies, and they're on Facebook Live, gonna do this whole thing for you.
You're all right.
Yeah.
Pass out or nothing?
Nah.
Okay. I guess I'll go ahead and get more detailed assessments, see if I find
Sure.
anything else.
All right, cool. You get a ample history, nothing really stands out. You get a last oral intake for me. You look at his head, face, neck. Does he need spinal immobilization, you think?
He's not complaining of neck or back pain, he didn't pass out.
Didn't strike his head or anything. I agree with you. Now, when you do palpate his abdomen, you got some tenderness in the right upper quadrant. There's no markings, no bruising. Extremities are good. Doesn't have bilateral elbow fractures like Paulie over there. And he's got a GCS of 15. So what do you want?
Radio pulses.
Present.
Alright, we'll probably just load him up, start my wheels, start him to the hospital.
Okay, where do you go?
Probably go to City Dallas. Unfortunately.
Okay. What do you think is wrong with the patient?
He could have some kind of abdominal injury.
Okay, very good. We got this set of vital signs for a 14-year-old He doesn't take any medications. What do you think? Sick or not sick? Yeah, probably not sick. You know, for a 14-year-old, remember, 200 minus 14, he can stand a lot of tachycardia. He's not even close. He's not beta blocked, no calcium channel blocked. It's pretty good. Is his normal blood pressure pretty close to that, you think, on a regular basis? Yeah, it pretty much is. Now, if anything, if you're still worried about that tachycardia, well, he could still be compensating for some stroke volume loss because of the right upper quadrant. What is he more likely injured if he does have an intra-abdominal injury? Right upper quadrant? Yeah, his liver. All right, so what are we going to do for this patient? We discussed SMR. He probably doesn't need it. Would you immobilize him, Paul? Probably not. I wouldn't.
I'm old, so that's probably not a good question for you. If you sneezed, I would put it backward on you. Back in 1990.
1990. So we go back to ALS treatment here. We do have a strong radial pulse. He is maintaining fine. We basically dissected his vital signs to know he's probably not far from where he needs to. If anything, he's got very early compensated shock. There is no indication for volume, okay? And even if he was, remember, we're still going to practice some permissive hypotension. Let him be where he is, all right? What would you give him for pain? Ketamine, cool, 0.1 to 0.2. What is the big side effect expected on a 14-year-old? Anybody know? Yeah, big one. By far the most common. You ever seen it? Yeah, so they wake up hallucinating, crazy, combative, angry, like they took a bunch of PCP. That's what they look like. What do you do about it?
I don't know, I left the room. I was the same one time, so
Yeah.
there wasn't any room for me in the room, but I think they just gave him I don't know if they gave him percentages.
Yeah, they come out like possessed. It's incredible. And then they get better all of a sudden. But just be on the lookout. They'll be doing great. And the moment the ketamine wears off, they'll go absolutely bananas. Not violent, just extremely confused, screaming. Just be aware of that. That's going to be by far your most common one. All right. On this patient, we did discuss the possibility of early compensated hemorrhagic shock secondary to an intra-abdominal injury. Remember, he does have abdominal pain, and he's got right upper quadrant tenderness. That equals an intra-abdominal hemorrhage until proven otherwise. 2, with that, we know that stroke volume more likely is going to decrease, which is probably driving up his heart rate in order to maintain cardiac output, and that's why we have a good, solid blood pressure, a good radial pulse, okay? Remember that if we do have hemorrhagic shock decompensated, there's only 2 things that are going to save your patient, which are blood and hemorrhage control. Yeah, hemorrhage control. 3, we remember that anything in the abdomen that is there that is not supposed to, like blood, pus, urine, feces, is going to cause abdominal pain. Always be aware that that's peritonitis. And now, this is where kind of modern education comes to play. Okay. Bedside ultrasound. Chief, are we ever going to consider ultrasound for your agency?
I don't think so.
Okay. All right. About June of last year, we did the first ever EMS ultrasound course, and here's my pitch to you. We were able to teach medics in 8 hours how to perform a very quick focus assessment, sonography, and trauma, fast, including a sono. So we taught them basically to take this kind of grainy, black and white picture into something they could actually interpret, all right? So the probe actually goes up here. It is right here in the right upper quadrant, facing upwards, kind of like a flashlight. What you're seeing here, the structure based on kind of what it looks like, that's the liver right there. That's the kidney that's got this kind of bean appearance to it, this central kind of white area. We know that's kidney. And we know in ultrasound that anything that is black doesn't belong there. It's either air or blood. There is no air or blood within the abdominal cavity, okay? So we were able to teach medics very quickly how to recognize blood. Now, somebody may say, I don't see any advantage to it. Can you guys find any advantage to doing a point of care ultrasound pre-hospital? What does that do for me? Yeah, exactly. All of a sudden, you're saving the patient approximately 1.5 hours of workup. Okay? Now, I probably don't need lab work. I probably don't even need a CT. I probably don't even need to repeat my own ultrasound. If you bring me an image for that 14-year-old, I'm taking that kid to the operating room, or I'm deciding whether they should have interventional radiology to clot off the bleeding. All right? So everything that you do pre-hospital really, really matters. Don't let anybody tell you otherwise. Okay. Somebody mentioned our receiving facilities, children's in Dallas, level 1, no ifs and buts. Now Medical City just received their level 2 trauma center certification, and they're open for business. This would be an adequate place to go for a patient who meets trauma criteria. How often do you guys go to Medical City? Once a year? Where do most of your kids go, like Legacy?
I've gone there.
We're starting to transport.
Yeah, we go there.
Way quicker for us on the east side.
Okay.
It's 75 up.
Okay.
Plus they ship everything out to Legacy.
Yeah, they do. Yeah, they'll go south.
You're going to
every
go to
time.
Legacy to go to Presby Allen. I mean, essentially the same level of care.
Who freaks out if you bring in kids? Like, does anybody ever freak out? Any hospitals that are notorious for freaking out if you bring in a child? They're like, oh my God.
All of them. They're like, oh, wait.
They're like, oh, not a kid. Not a kid. Okay, awesome. While we're on the subject, and I promise then I'll shut up, is needle thoracostomy for a really bad day, okay? We've always taught you the landmarks. Mid-clavicular line, second or intercostal space, that's fantastic. We use this, of course, for a tension pneumothorax, and we know we have a tension pneumothorax if we have two things and two things only. One is evidence of a pneumothorax. It cannot be a tension pneumothorax if you don't have clinically a pneumothorax. Decreased breath sounds, trauma, markings, on and on and on. And two, you gotta have some evidence of hemodynamic collapse. Give me some tachycardia, some hypotension, some evidence of shock. If you have those two things in the right clinical setting, we gotta needle that patient. I promise you that we'd be as progressive as we can. This site right now is primary. This is going to become the secondary alternative site. The modern medic has to be aware that the new landmark going forward is going to be mid-axillary line, 4th or 5th intercostal space. Why is that? Well, we've studied this ad nauseum, especially in the military. The amount of tissue between here and my thorax is a lot bigger, especially in bigger folks, than the distance from outside to the thorax here, by almost half. So we're more easily accessing the thorax right here. All right, the downside to it, well, I've actually seen, including some good friends of mine, do this, go too low and actually put it in their kidney or spleen or even liver. I've seen that. So we gotta go as high as we can. This is actually where we put chest tubes. Those of you who've done work in the department, that's where we put chest tubes. And no, don't worry, you're not gonna mess up my chest tube site. I don't care what anybody says. So going forward, this is actually gonna become a secondary site for needle thoracostomy for you. Okay? Is this what you guys carry, this one, or we just brought it? Okay, very good. It's a 3 1/4, 4. Yeah, I like that, you guys. It's pretty awesome. Tell you, I'm a big kid. Okay. All right. I don't know where I put my clicker. Awesome, guys. We're literally done. Just to drive the point across. Remember that we gotta go right over the rib, all the nerve bundles and vessels. Sit right under the rib. Try to go around the rib. The way I do it is I find my fingers, I feel a rib, and actually just try to do this and actually push my finger over the ribs like this, and I drive my needle over it. That way I know I'm directly over the rib and not under the rib that's right above it. Okay? And we access the pleural space and we decompress until no hissing is present. What if you get a gush of blood? You got a hemo? Is that the end of the world? Nah, you're evacuating a hemo. That's fine. You can cause a tension hemothorax. Tension hemothorax can be just as dangerous as a tension pneumothorax. So evacuating blood is actually okay.